So let us continue with our session on microbiology tests for rapid, early, and accurate diagnosis. Let us learn about let's see about sepsis. Improved diagnosis of sepsis, but only a few biomarkers have impact on therapy and fulfill the clinical requirement for sepsis diagnosis. What is the best test for a sepsis biomarker? Well-defined cutoff level, favorable kinetics to determine start, peak, and end of an infection, sensitivity, negative predictive value, and area under curve approaching 100, and specificity and positive predictive value more than 0.85. It identifies condition prior to clinical signs and predicts progression and prognosis of conditions, low blood volume and fast turnaround time, low cost, early diagnosis, and should facilitate therapeutic decisions. There are various sepsis biomarkers for neonatal sepsis. We have WBC, platelets, and series, and many other cultures and acute phase reactions, pre-sepsis, other studied biomarkers, molecular techniques, chemokines, and cytokines, as you can see from this picture. Many are available, but none is ideal. It should be used in conjunction with clinical assessment and other lab tests. It should be used with caution. Currently used biomarker for diagnosis of neonatal sepsis are WBC, C-reactive protein, procalcitonin. You can see the sensitivity, specificity, PPV, and NPV from this slide. Then interleukin 6, then interleukin 8 are the other biomarkers for diagnosis of neonatal sepsis. The common biomarkers are CRP, C-reactive protein. It is sensitive but not specific. It is increased in many inflammatory disorders. Then we have procalcitonin. It is increased in many inflammatory disorders like pancreatitis, polytrauma, and major surgery. It helps rule out infection, but increased PCT does not always indicate infection. C-reactive protein. It is an acute phase reactive protein produced only by hepatocytes in response to inflammation or tissue injury. It is a slow induction. Level increases after 6 hours of inflammation with peak around 48 hours. Then it has low specificity. It increases in minor inflammatory reaction, viral infection, non-specific stimuli. There is no correlation with severity of infection. The CRP can be used to monitor the course of infection, but value may remain high over a prolonged period even after improvement of the inflammatory situation, which is useful for early onset sepsis in neonatology. The procalcitonin test is a precursor for hormone calcitonin. The normal serum levels is about less than 0.1 nanogram per ml. Improved specificity in diagnosing bacterial infection and helps in distinguishing from viral infection in early course of the disease and other causes of infection or inflammation. It is a rapid induction. Level increases as early as 2 hours after inflammation and peaks by 24 to 48 hours. The peak levels roughly correlate with the severity of infection. With resolution of inflammation, the levels quickly decline at a predictable rate. After reaching peak, the levels decline by about 50% every 1 to 1.5 days knowledge. Cost is a major determinant of procalcitonin. What is the clinical significance of biomarkers? The CRP and procalcitonin are most evaluated biomarkers to diagnose bacterial infections in septic shock, in sepsis, and community occurred in many patients. It is a good but imperfect diagnostic performance. No role in routinely guiding the initiation of antibiotics in ICU. Clinical judgment is very essential. A good rule-out test is procalcitonin levels less than 0.1 nanogram per ml. It has a high negative predictive value, about 96%, for excluding bacterial infections and stopping antimicrobials. In pneumonia, if CRP is less than 10 and in sepsis less than 15, it can be used as an indicator to stop antibiotic, but no clear guidelines. Useful biomarker to discontinue therapy after clinical stabilization. PCT non-clearance is a predictor of mortality in patients with sepsis. PCT of a value of a range of about less than 0.1, then bacterial infection is unlikely. No antimicrobials are needed. Consider repeat CT 24 hours based on clinical cities. Procalcitonin about 0.1 to 0.2 nanogram per ml. Bacterial infection unlikely. No antimicrobials. Use of treatment is based on clinical status. Level more than 0.25 to about 0.5. Bacterial infection is likely. Antimicrobials are needed. And repeat PCT test at day 3, day 5, and day 7. Procalcitonin level more than 0.5. Bacterial infection is very likely and antimicrobials are needed. And consider stop antibiotics when 80 to 90% decrease. So there is no biomarker test that can differentiate the bacterial and viral infection. About 1156 hospital patients showing that mortality rates were 2.6 times higher in patients presenting sepsis on the general ward with PCT consideration more than 0.12 than in those with lower PCT levels. PCT concentration could thus be used to help identify which patients which may benefit from ICU remissions. You can refer to this observation in Journal of Hospital Infectious. PCT concentration decreased by more than 50% over 72 hours than in the other patients. Trends in concentration over time are clearly of more value than single measurements. Increase in CRP concentration in the first 48 hours of therapy suggests that antibiotic therapy may be ineffective and need reevaluation. PCT concentration in an antibiotic experienced strategy is not a wise strategy, and it may result in worse outcomes. Let's see about the fungal biomarkers. Galtoman and beta-glucan are the fungal biomarkers. Galtoman detects aspirated infection. FDA approved only serum and BAL, that is bronchial levels. The tools of test is a high negative predictive value. It is a screening test in a high risk patient who are asymptomatic, but not on active antifungal prophylaxis. Serial serum GM Galtoman testing is useful in initiation of antifungal therapy and monitoring of patient's response and clinical outcome. PCT CRP, to summarize, there is no role in routinely guiding the infection initiation of antibiotics in the ICU. Clinical judgment is necessary. A good rule-out test PCT less than 0.1 have a high negative predictive value for excluding bacterial infections. In pneumonia, if CRP is less than 10 and in sepsis less than 15, it can be used as an indicator to stop antibiotics. It is a useful biomarker to discontinue therapy. PCT non-clearance is a predictor of mortality in patients with sepsis. Galtoman detects aspiration infection. Serial testing is required for initiation of antifungal therapy and monitoring of patient's response and clinical outcome. Let us see the difference between beta-glucan and galtomanin. In terms of aspergillus, beta-glucan is yes and galtomanin is yes, but Candida it's no for galtomanin. Pneumocystis again it's no for galtomanin. Mucormycosis is no for both glucan and galtomanin, while Cryptococcus is again no for glucan and galtomanin. Let us see the difference in details. Condition that can cause false positive in beta-glucan galtomanin. Drugs responsible for false positive results in beta-glucan are IV amoxicillin, coamoxiclo, IV piperacillin, tazobactam, IV immunoglobulin, albumin. While in galtomanin, beta-lactam antibiotics, enteral nutrition, foods like tea, milk, aspiration pneumonia causes false positive results in galtomanin test. In bacterial infections, responsible for false positive results are Streptococcus pneumonia, Pseudomonas aeruginosa, Alcinogenes faecalis. Clinical interventions like dialysis and intraoperative gauge are responsible for false positive test results in beta-glucan and galtomanin testings. Regarding sensitivity specificity, for galtomanin, the sensitivity is about 60% and specificity 93% for serum, while for plasma it is 87% and 89% sensitivity and specificity. If you see beta-glucan, it is about 90 and sensitivity is about 96%, specificity is about 84%. While for the immunosuppressed, it is 80% sensitivity and 82% specificity, and for ICU IFI, that is invasive fungal infection, it is 90 to 100% sensitivity and 57 to 94% specificity. That's all from this session. We'll see in details about the POCT in the last session. Thank you.